Well, first, thank you so much for having us. It's an incredible pleasure, actually, for me to come back to the South. Now, where I was from in the South, you might call the North, but we called it the South. Because I trained at the University of Virginia, which I enjoyed enormously and I miss. And I come back here, I realize all the things I'm missing. But I think I also learned at Virginia that if you like a place and you feel honored by a place, you don't tell them what to do. So there's nothing about this talk where I would be, or Arun would be, understood as telling you what to do. Certainly not. Instead, I think we want to share a story of something that we did that we really, I think, find meaningful and interesting. And I think there's a lot of rich education in the story that you might find fun too. But I don't want you to hear us as sort of selling a model or selling one way. It's just, I guess, our joy, and we'll share our joy with you, as you have clearly shared with us. Now, I have a problem which has nothing to do with North, South, or Virginia, or Georgia, or anything else. My problem is I speak too quickly in any environment, including my own home. So it's just me. So if that happens, you're allowed, I know how polite, I know, but you are allowed to just go like this, or any gesture that you would need to slow me down. It'll be my excitement that speeds me up, so please slow me down. All right, so the story we will tell you is about the Longitudinal Integrated Clerkship. They're called LICs by some. I see you used to call them LICs. We call them LICs, Longitudinal Integrated Clerkships. Harvard Medical School has one for about 9 years now. All right, so we should thank Harvard and Cambridge, who allow us to go around and talk about things, and all these nice foundations and generous people who helped us start this, and this international group of schools. And there's a large group of schools now across the world that are doing these models who are very supportive of one another. No good project gets done without a great design team. So I always like to mention Barbara Oger, who was there from the beginning, and of course Arun, who's been there in the surgery component from the beginning. And I think you and I are the last two remaining holdouts from the very beginning. And the rest of our wonderful team. All right, so for the talk, we'll do the case for change, like why change education? You already have a great history of education here. Why should anybody change education? What is the science that underpins education reform? And we'll tell you about the model that grows from the case for change and the science of continuity. We'll give you data. You should not want to sort of hear just a mythic story, but rather the data, and we can think about lessons in the future. All right, so the case for change rests on 3 issues. One has to do with the Abraham Flexner's report of April of 1910. One has to do with this notion of the literature on ethical erosion. And one has to do with connecting clinical learning to all these sciences of learning that exist within and outside of medicine. There's lots of sciences about how people learn. So we'll start with Flexner. But first, I want to also characterize that we think of it as not enough simply to have our students become more able. We also want them to be more special in character, in their manner. If yours is a place of community engagement and character and these kind of values, that also we feel is part of our responsibility as teachers to help. So it's principle-driven education that's also principled education. So to Flexner we go, back to April of 1910. All right, Flexner, has been sort of revisited in the 100-year celebration about a year and a half ago. And the devil quoteth Flexner to serve his or her needs. So I'm not going to do that. I'm going to offer you a piece which is part from the general part of the Flexner report, but clearly it serves my needs. Devil that I am. So in this wonderful part of Flexner's thesis, he mentions 3 core things. The diversity of the conditions and the number of conditions students may face and see from which to learn. The continuity of the service on the part of the teachers of medicine. And the closeness that the student can follow the individual patients. These were the core Flexnerian principles that he was judging all these schools by. So these are the things I want us to hold on to, because people will say, well, this model of yours, it's so new, it's so radical. It is radical if we use the proper definition of the word radical. A radical movement is one that returns to its roots. A radical of an equation, is the root of something. And this is actually a throwback to the old roots of medicine, as when my father and my grandfather's 2 sisters actually trained. It was when teacher and student and patient were closely connected. The student could know from their teacher, the teacher could know from their student. That was a relationship that was powerful. And the student could know their patients very, very well, their patient's experience of illness, their patient in context. And they could see the evolution of disease and the evolution of the diagnostic and therapeutic interventions. This is a return, actually. In that way, it's radical. It's not something new and different otherwise. We're trying to get back to Flexner's core principles because we think the principles remain right for learners. The problem is in Flexner, in our view, the problem is that the context of care is nothing like it was in April of 1910. Patients in April of 1910 could be in the hospital for months as you watched the evolution of disease, and as you and your faculty person together cared for the patient for all those months. But nowadays, your patient's in there for minutes or a day or two, and your faculty person is also not there with you for the time, and residents come and go and change. So it's not the Flexner we worry about, it's the context of care. Ethical erosion is an interesting literature, a different perspective on why change. Ethical erosion, kind of simply put, is what happens as a negative consequence of clinical training in the current era. So students decline in professionalism, as broadly defined, as it relates to their clinical training. So students will witness, take part in, and have bad feelings about bad things that happen in their clinical year as they take part on these house officer-led teams in big hospitals. And there's lots and lots of literature on this, not least of which was the original paper where the term ethical erosion was coined, where Feutner and Christakis basically took 665 students who responded to a survey in the 6th Eastern Pennsylvania Medical School. That's a huge survey. 6 schools, 665 respondents. And there's all sorts of things in the paper that they looked at. I can just point out two, and the case is made easily by two things. I'll show you the longest bar and the shortest bar. The longest bar is 98%. That's the number of the students, that's the percentage of all the respondents who said they heard derogatory comments about patients while serving in these inpatient venues on these house officer-led teams. Now, it's an interesting question. What percent is okay there? I mean, if half the students heard derogatory comments about their patients, would our CEOs be happy? Patients' families be happy? I mean, 4%, what's the good? I think the number is 0. How about the shortest bar? The shortest bar is 32%. That's the number of students who said they felt like an accomplice to a crime as a consequence of working on house officer-led teams in big hospital venues immersed by discipline. Well, we could throw this survey out and say this survey is not so, but this is ridiculous. The students had biases. They don't understand what it's like to be a doctor. Fair enough. But what it did was this original survey generated a literature. So many, many people studied this in many, many ways hereafter, and I'll quickly give you some of them. Those who studied patient-centeredness, Paul Haydett and colleagues, used validated tools for patient-centeredness, and what happens? In the 3rd year of medical school, students decline in their patient-centeredness as a consequence, they believe, of being immersed on those teams in those venues. We can think more about this. I'm not trying to push anything, but at least those who study this aspect found disturbing news. How about those who study vicarious empathy? Multiple scales in multiple places, vicarious empathy declines in medical school, principally in the 3rd year. All right, we can reject that too. How about the validated tool for moral development? It's in several countries and several languages. It's been validated again and again and again across and within disciplines. The DIT-2 scale from Minnesota, the work of Lawrence Kohlberg. Students decline in their moral development compared to age-matched peers, mostly in the 3rd year of medical school. Many write about that one. There's many others still. I just try to pick my favorite ones. Now, it turns out that moral development this was challenged. They said, you know what this is? They go and they see life and death. It's like the Garden of Eden, right? If you bite of the apple, you come to know life and death, and you're changed forever after that. Of course, what should doctors do? What should Adam and Eve do? They covered themselves up once they knew of life and death, of good and evil, right? So maybe we doctors do that too. Maybe we cover ourselves up. We efface too much. We don't connect to our patients in the same way because we know of all these things. Well, it turns out it's actually medical school and not other professions that do caring. So when they look at other professional schools that involve caring, it wasn't happening there, but it was happening in medical school. So it's not just about kind of caring and life and death and so forth. It's something particular in medical education, it seems. All right, not convinced? The others studied and showed that moral development and overall competence co-vary. Now, that was kind of compelling because it's not just sort of a carved out issue of being nice or not nice or not empathetic or patient-centered or not patient-centered. It's about being excellent broadly defined. And maybe you could flip it and say, well, how about this one? Those who have trouble with moral stuff in school now are those who have trouble with moral stuff in life later. Lots of studies in lots of places, not least of which is Maxine Papadakis' work at UCSF. At any rate, whether we buy at all or buy part of this, there's something happening in ethical erosion that would compel us to rethink the venues of training and the methods of training. All right, so we've done Flexner, We've done the ethical erosion. How about we could throw those two out and just ask a more basic question? If we knew all about the learning sciences, whether it's the neurobiology of learning or neuroscience of learning, social psychology or education, the expertise literature, the workplace learning literature, pick your literature. Would you make block rotations immersed in venues with the most junior people who are not trained to do the teaching, doing the teaching around complex issues for students who will have non-meaningful roles? It's kind of a rhetorical question, I suppose. But all right, but anyway, so we looked at lots and lots of learning theories to see if they were well aligned with the current model. And these are some of the theories that people suggest would be, if you consider them, you might change your model. Then there's the expertise literature, which would suggest changing the model. The workplace learning literature, the self theories, which is one of the most brilliant, the self theories literature. It's about resilience and growth. All these other learning theorists we looked at, the adult development literature, and it's also links to the moral development literature, and even the leadership and change literatures. So there's a lot, not of literature, but of fields of literatures that would suggest that a new model was in order. Bless you. And there are lots of ways of imagining what a new model might entail if you're trying to get at the outcomes we seek as a community of teachers who care about our learners and our patients. So this leads us to this notion of continuity. So in this article, we made the argument that continuity of care, of curriculum, of supervision, and the continuity of their core ideals that bring them into healthcare professions in the first place are continuities worth preserving. The continuity of care basically means the patient needs to matter to the learner, and the learner needs to matter to the patient. I can say the continuity of supervision, similarly, the student learner needs to matter to their overseer faculty person, and the faculty person and their views and their model and their experience needs to matter to the learner too. What does this lead us to? It leads to longitudinal connections that are much more deeply integrated, that are based in relationships, professional relationships. So students can learn to grow and be and do more in a more refined way because of this kind of oversight. And yes, you can smell on this the old Flexnerian idea that's sort of apprentice-like. Someone actually looking after, doting upon, caring after the learner to make sure that that learner is doing for patients what the learner must do. It's not a single apprentice as it was back in the medieval times, right? There's many, many overseers and many, many places where people are overseeing, but the oversight is much more tight and close. So again, don't let me escape with any kind of cute play of words. This notion of longitudinal integrated learning is also deeply, deeply rooted in evidence. And if you want to forget all the other learning theories and so forth, this singular paper might be one that would be most compelling. They looked at all of these literatures, the high science from these literatures, and which things were and were not being employed. Recent research on human learning challenges conventional instructional strategies, they argue, two of the leading thinkers about education in the world. So we come to it hopefully because we're trying to derive educational structures out of science. So what does that lead us to? We're talking about this continuity notion now, and continuity is what I'm going to tell you at the end. But what do we have? We have blocks currently. We can put intercessions between the blocks, maybe one where neurology and psychiatry are woven together, or I don't know, OBGYN and pediatrics are woven together. There's longitudinal themes, like you could do medical ethics or quality and safety, but they're not courses, they're just important themes you could weave through curricula, but the blocks persist, you see. Or you could have blocks where you have inpatient mostly, but outpatient a little. We know this, right? In surgery and medicine, maybe yellow and green, you see such models. Or you could do longitudinal family practice or longitudinal primary care or some kind of clerkship that sits on top of the blocks. Or you could do blocks that go inpatient, outpatient, different inpatient, same outpatient, as the San Francisco VA does, for example. But in the end, they're all blocks. And blocks are the problem. Blocks are the learning problem. Blocks are the professional development problem. One of the great papers really ever written, which another one I want to highlight for you, was written by Dimitri Christakis in the JAMA in 1997, where he titled it, you can read the paper, or the title itself may tell you what you want to know. He called the paper Temporary Matters, as in matters of time, but also matters of temporariness. Time matters or temporariness matters. Temporary matters, : the ethical consequences of transient social relationships in medical training. there's something harmful that happens because of the blocks. The block problem links to ethical erosion. The block problem violates Flexner. And the block problem violates the learning sciences across field after field after field of the learning sciences. And it makes you want to say, wait. We trained in blocks, and we trained in blocks. We trained in blocks in many places. Who did not train in a block here? Right. So the question I want to pose to us is this. It's not the question of are blocks bad, are blocks evil, are blocks ruining the world. It's not that. Blocks are good, they're fine. The real question, though, I think as we're scientists and we care about patients and we care about all sorts of high ideals about the world and our community, the question is, are blocks the best? Or is there something better? Can we do better? Look at the city out here in Rome. It is unbelievable. It's been renewed and rejuvenated, and people have gotten together as a community to plan the future. Hospitals are linked with other hospitals and do projects together. They do medical records sometimes together, apparently. I mean, PACs together. Who does this? The question is not whether blocks are good and fine. They are. The question is, are blocks possibly in the way of progress towards a better health system or better education or a better future? And they are in the way of that. There's something better beyond blocks, and it's probably streams. Streams are about the core of medicine. So you've just taken your blocks and you've stacked them up in a pile, and you've pulled them long now. So you see surgery, the yellow lasts the whole year, and OBGYN, the blue, lasts the whole year, and peds the whole year, medicine the whole year. You do things simultaneously, and you'll notice too that I don't know how to smear on PowerPoint. I love to smear, but I made dotted lines. So the idea is that the lines are perforated because there's no such thing as a neurology patient. So today I'm in front of you enjoying this time together, and I'm an internal medicine patient. But if I get a headache tonight, I'm a neurology patient. And if my headache comes with a rash, then am I back to medicine or am I a derm patient now? Right? People don't become a patient of a discipline. People are the site of integration. Our great surgical friend, one of the leading surgeons who Arun raised up, she was the one who said, the patient is the site of integration. If that's the point, then we must train understanding that way of knowing. So we tried to show that you can perforate the blocks. Why? Because if your surgical patient today becomes pregnant tomorrow, you can still follow her. Or if your medicine patient today needs to go to surgery, you can follow him. You can follow your patients across the disciplines because life happens across disciplines. The patient becomes known as being a patient, not as a discipline. It matters. And it matters for learning, and it matters for the ethical erosion. And we'll show you. So how might this, I picked medicine. Later tonight we'll do an example from surgery. Imagine a student has, I'll go back for a second. See all the different disciplines? The students will have cohorts of patients in each of the disciplines. They'll follow their own panel with their own tight overseer physician, looking after them, following the panel. So here's an example of an internal medicine panel. A student has a bunch of patients they're going to follow for the year, and a bunch of patients they're going to see that they may not see again. But for the ones they will see again, longitudinal that is, you can hand make a deliberate panel of patients who have the core conditions afflicting society, and you can follow them inpatient and outpatient. The last two required surgery in this case. This is actually a real student's real panel. So outpatient to inpatient, back to outpatient. You can follow the patient in and out. You can follow different patients with specific conditions. You can make a non-random panel, right? So how many people here do, let's say, do internal medicine or family medicine? Family medicine, right. So yeah, so then heaven knows you know what a diverse panel of patients looks like, and you know what the core conditions are that afflict this community and humankind. I had the interesting pleasure, it was a pleasure, an honor really, to admit a boy who was 10 years old 3 times during my training. 3 times in 1 month I admitted this boy with congenital citrullinemia. So I've asked the question in, I will tell you, scores and scores of places and countries. How many of you have ever seen or cared for a child with congenital citrullinemia? Right, so my number still stands at 1. Right, there was one metabolic physician in Colorado who had, right? But I admitted that child 3 times, and it was meaningful because I cared for the family and the care for the child, and suffering is always important to learn how to engage. But the problem was, during that same month, I did not admit fever in a child, diabetes, pneumonia. You get the point, right? Otitis media gone bad. I did admit failure to thrive on several occasions. The failure to thrive would come in like this. That's a pile of charts. So the baby's been to the Mayo Clinic and the Cleveland Clinic and to Michigan State, and actually they were out in Texas for a while and the University of Rochester, and we don't actually know what they have, so can you try to help us render an opinion? Me, the intern, right? That for the baby, this matters. Like, I care for that family, I care for the child, and I would never want to diminish how important it is for that family, but clearly as a training question, it's not like having the experience with the core conditions that I would need in my most basic of training. Certainly in medical school, you want more of the core conditions. And you want to see them more times again and again. So here you see an example of a medicine panel, and you can imagine a family medicine panel or a psychiatry panel or a pediatric panel, non-random, where the core things are the things the students do, and they do again and again, because they're seeing what they perceive as their own patients. They start to see it as their own panel and their own patients. Imagine how they act then. The month's not going to end and go somewhere else. This is my patients with my preceptor in my clinic for a year. And the my matters. Because with ownership and a sense of duty and a sense of commitment, you change entirely how people learn. So it's very interesting, I would say. They can follow their patients through all the venues of care, and they run into all these specialists and all these disciplines and venues along the way. So that was just medicine. And I put this up, believe me, you do not need to learn this, but frankly, Dr. Reeves showed me his a plan that he was thinking of, which is, I think, far more elegant than ours. I like yours much better. It's clearly an advancement. But I only show it to say that it's doable. And how you do it is, the students will have, let's see how tethered I am here. Whoop. All right, we'll give it a go here. If I fall, it'll be funny. All right.
We have orthopedics, sir.
Exactly. So you can imagine neurology every Monday morning for the whole year in your neurology clinic with your neurology patients, with your neurologist overseer. There's sometimes when it's actually open space for the students to work on covering their panel. They're not forced to be in a venue at that time, but they work on covering their patients. They do home visits. They work on quality and safety projects or leadership or management projects or community-based things. Or mostly what they do is they study and learn and read. Every Tuesday morning, they're obstetrics and gynecology. They're brought together for tutorials about basic science and population science. There's more open space, peds, medicine. You see, the whole year they have a map like that where they just are in their clinics with their panel, with their preceptors for the whole year. And they can't get stuck seeing things through only one discipline's eyes. It starts to become, and if there's lots of family doctors here, you'll know this, you can't see things through only one set of eyes. And frankly, neither can any other specialty either. So Arun is really too modest to say, but a master surgeon who's trained in many subspecialties in many places, including Harvard, but many others too. And if you drop a case of a patient in front of Arun, what happens? You have to figure it out, because sometimes it's not surgical and sometimes it is surgical, and sometimes it's actually psychiatric and sometimes it needs surgery but not now. There's no such thing. It's always the discernment that matters in every field. So this actually forces them not to get stuck in their discernment skills. All right. Here I just show a little thing. You might say, well, they need more surgery. Boom, boom. Okay, I'm going to turn it green. Periodically throughout the year, they'll have bursts of surgery, an invention that Dr. Ghosh herself has come up with, because the key thing is to be present when people are discerning, should it or should it not be a surgical case? Does it or does it not go to the OR? Is it or is it not part of our surgical team's work, this patient I see? So they start on call, and they follow with the surgery team for a couple of days in a row, because that's when they can link up with the team. They can follow cases through that they saw on call. Now in the morning, see how it says pre-round on Thursday and Friday? They can keep going following their patients even after their regular schedule comes back. I'll do it again. So they have a regular schedule, a base schedule, and we can put down 2.5 days of surgical work just periodically throughout the year, bursts of surgery bursts. So they keep getting chances to have these dense OR surgical thinking times. We don't want them to not have that. Why would we do that? That doesn't make sense. Because a panel like this, even with a large panel, not enough patients will go to surgery in a year. So you have to make sure they have other chances to pick up surgical patients and follow through the thinking, the seeing, the OR, the post. So there's that. Now I would have played for you the story of Florence, but I will just quickly tell you that this is a story of a student who characterizes seeing a patient across some dozen disciplines and venues. She picked up a patient in medicine she saw in so many places with these various preceptors, and she became so able to know the patient's condition that she was greatly helpful to every team that she, the student, arrived at. Who is this student now? So this student did her research. She's a surgeon in Seattle, and she wasn't in med school to become a surgeon. She converted to surgery because of Dr. Ghosh. I mean, it's the story, yeah. If I hear one more, Dr. Ghosh is God, out of her, yeah. Around here, we don't say those things lightly. But the thing that's fascinating for me is what was it? Well, I mean, what did you do? What all Dr. Ghosh did, respectfully, is give the student the chance to see surgery the way that surgeons see surgery. She wasn't just the junior most member on a team. She was in the back pocket of a surgeon for a year. She was in the back pocket of the surgeon's patients for the year. She saw those patients in and out of surgery, and sometimes those same patients who had a surgery at one moment delivered at another moment or went to psychiatry at another moment. They were people. They were Dr. Ghosh's patients. They weren't the leg in room 4. And in fact, her most important story, that's why the story is called Florence is a Real Woman, because she went to a party, Dante did, and all of her block clerkship trained Harvard peers at the party saying, oh my God, I saw the stinkiest foot today. No, forget that, man. I saw a leg come off. Referring to body parts, diseases, conditions, and pathologies. And Dante says, she says in this thing, that's kind of strange. I never thought to see patients that way. It was Ms. So-and-so, the lawyer who had gangrenous whatever, or Mr. So-and-so, the pharmacist who had X. It was always a person, a real live person, who she knew and cared about, who developed a thing. Suffering. So you can learn a lot of science when the suffering is your driver. So anyway, that's the story. It won't play, but you get that's the key idea. We can try to get Dante to you later. So we try to. So fair enough. So maybe there's a compelling argument, but the data has to say something. So this paper on top is no longer in press. It was published a couple months ago. But anyway, there was. People apply to the Cambridge program by volunteering. There's no application, they just volunteer. And they're chosen at random out of the volunteer pool, and the others who were not chosen became the comparison group. There were a few other students thrown into the comparison group, which kind of dirties that comparison group a little bit, I'm sad to say. But nonetheless, you've got basically like compared to like, and everything we looked at between the two groups was the same. We couldn't discern any difference between the two groups, so we could compare them. They weren't randomized, though, I want to say. Ours were drawn at random, but they weren't randomized. You with me? So, because there's still some other people in the comparison group who were not volunteers. Anyway, if this all works out well, and I think the data is going to say that it did, but if it all works out well, but it wasn't the program that we said it was, then who cares? I mean, so the question is, was it longitudinal and taught by faculty, and were they close to patients? The Flexnerian ideas. Longitudinal has two definitions, I want to say. Longitudinal could be seeing the patient again and again, or seeing them over a long time, or dealing with chronic illness. But longitudinal, in the case of the surgery bursts, what did it mean? It meant the students were there at the beginning, when the whole discerning was happening. They followed how the whole thing progressed, were there for the sentinel moments, and were there in the denouement, the after. That might only be 3 days. Some patients have an appendectomy, and they're in and out, and they're done. But the student was there longitudinally for the entire course of illness, or we call the whole illness episode. So there's kind of acute longitudinal and chronic longitudinal, if you think of it that way. Anyway, let's see. How often have you been involved in seeing patients you've treated before their diagnosis, before the decision to admit? Were you part of the whole thing? You see Cambridge in the blue, you see the rest of the Harvard students who did traditional blocks in the Harvard-colored crimson, the P of less than 0.05 for the difference. Cambridge students did see patients before the diagnosis, were part of it, and the comparison group was not. The comparison group got usual care. You may recognize usual care. I had usual care, you had usual care, I think we all did. Here's usual care. Beep, 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 beep. I pick up my little beeper as a student. Hi, it's Dave. Right? All excited. It's Dave. They actually called me. It's Dave. And they say to me, yeah, so Ms. So-and-so was just admitted to the 4th floor with chest pain and ruling out MI now. So we gave her aspirin, heparin, and a beta blocker. She's upstairs on tele. We decided to give her heparin too. The T waves are kind of atypical, but we thought maybe there was some subtle ST changes. You can see the EKG. Anyway, she's up on telemetry up there. She's really nice. The intern's seen already. The note is done. So why don't you go see her and see what you can do? It's done. It's done. They don't. If I didn't do it, nothing would happen to Ms. So-and-so. I mean, maybe she'd be healthier if I didn't engage her, right? Right. So if I do it, it's clearly all for me, which teaches a strange lesson. Patients are here for me, right? I'm paying tuition. They're here for me. How about if the situation were different? How about beep, beep, beep. Hi, there's a patient in the ER with chest pain. The team's going down to see her. Come on down with us. Or you go see her. We'll be there in a minute. right, where you're part of the front end. You're not left alone to do the case, of course not. But the student is part of the discerning. Okay, so that's what this blue and maroon comparison here shows. How about after discharge? You see 90% compared to about 3%, a p of less than 0.05. So they see patients before diagnosis, before decision to admit on the front end, and they see them after discharge, p of less than 0.05. How about who teaches you? How many hours are you taught by faculty? The p is less than 0.05, favoring the Cambridge model, or the Harvard model, as compared to the traditional blocks. Or of the feedback you got, who gave it to you? The Cambridge students, the LIC students got much more feedback from attending physicians than did the traditional blocks. And there's a third one I could have put over there. Of the mentoring you received, how much was by faculty? The Cambridge students were faculty taught, the block students were not. The p is less than 0.05. So far we have longitudinal, we have faculty taught. As to closeness with patients, how often would you describe your connection to patients as meaningful? The Cambridge students very often are often 100%. Here I think I could go home now. I mean, they were meaningfully engaged with patients, and that drove their learning. The patient's needs drove their learning, and they were meaningfully connected. The patient mattered to the student mattered to the patient. You see the difference. How about you felt you made a real difference? Again, the p of less than 0.05. So it was longitudinal, it was faculty taught, they were close with their patients. It seemed to be that what we said we were doing, we did. All right, you should not be convinced yet. That's not data that says it's any better or worse. It just says that we did what we said we were going to do. No one's convinced without having the hard, classic, typical data of exams. So here's the hard, classic, typical example from exams. I pulled it apart some. I could have pulled it apart more. 4 different exams, shelf exams, were done at Harvard back then. That's all the shelves that were done at Harvard back then. You see Cambridge in the first column, the comparison group in the second column, and the p-values. If you add it all together, the p is way less than 0.05. But I pulled it apart so you could see shelf by shelf. Now, you could say, yeah, you're still fudging, because it's 3 years and 4 tests. There's actually 12 things you should show us, not this. Fine. Of the 12 tests Cambridge students took and comparison students took over a 3-year period, none had a significant p-value that went to the comparison group. 9 favored Cambridge, and you can see if you put it all together, here's the p-values. So maybe they do better on tests. At least they do the same. They don't do worse on tests, it appears. Nor did they do worse when the first year Harvard piloted doing the medical knowledge self-assessment program, the MICSAP. It's the content test for medicine for 1 year. Cambridge did fine that year too. Or how about the boards? You see Cambridge, you can see the comparison group, you see the p is not significant, but you see the trend to Cambridge. What if, now they stopped the trial after 3 years, so we have no comparison group after 3 years. But we had Cambridge after 3 years, so what if you put the 4th year of Cambridge against the traditional comparison group? It becomes significant. Maybe that's cheating, but at least they're not doing worse on content tests. Or on OSCEs. Harvard has a make or break OSCE test in its 4th year. You've got to make it to pass through the school. And each year and every year, the trend is to Cambridge and the p was significant. So they're not doing worse on that either. So I don't want to tell you that they will always do better in every discipline all the time. But they didn't do worse. The big fear was they would do worse in longitudinal models. Maybe they did better. But how do they feel about it? How well does this adjective describe your clerkship? Hectic and stressful with significant values. Cambridge was more hectic and more stressful, and equally frustrating. More hectic, more stressful, and equally frustrating. But it was less boring, more satisfying, and I can show you breakouts of satisfaction, more humanizing, more hectic, more stressful, equally frustrating, more humanizing, more rewarding, less marginalizing, more confidence building, and more transformational. It was hectic and stressful in service to something, not hectic and stressful because I'm being mistreated, abused, or ethical erosion stuff, not hectic and stressful for no reason. Clearly hectic and stressful, we're doing something good. How about, well, maybe Cambridge is a soft, cute, little nice place and everybody's really nice there and it's easier. Actually, it turns out they had fewer hours to study. They complain about that. They studied more. That's kind of interesting. They saw more patients across the course of the year by a lot. Had more clinical experience. That's why they had less study time. And when asked if it was harder or easier, they were more likely to say it was too hard. They were less likely to say it was too easy. And what's more interesting to me, I love this one, the further the year went on, the more the comparison group said it's too easy. And the more the LIC students said it's too hard. The longer it went, the harder the LIC students felt it was, and the easier block students felt their experience was. Because doing the same stuff simply in a new discipline or in a new venue is not harder. It's just code shifting. But having a bigger panel where more is expected of you by your very hard and tough preceptor who demands more of you because they expect you to know something because you've known them for the whole year, that's harder. Satisfaction across a wide variety of measures, satisfied with mentoring, with the atmosphere, with the quality of feedback, with the quality overall, was significantly different. It remains so up to the present. How about how do you perceive things? How do you perceive the extent to which your LIC experience prepared you to be self-reflective or have a knowledge base to be competent or deal with problems with no clear answers or to understand the healthcare system? Now, you would say, I think appropriately, yeah, so they felt they were better. They weren't actually better. Oh no, I'm not saying that they're better at these things. They just felt better prepared. And they felt better for these things, to be truly caring, to deal with ethical dilemmas, to understand social context, to involve patients in decision making, to relate to a diverse population. So they felt better about those. 2 more slides of data. We made this big, grand claim that people ethically erode. We don't, of course, but everybody else out there seems to ethically erode. Well, the literature showed again and again and again that students decline, as the dark blue line shows, in their 3rd year on measures of patient-centeredness. The validated tool is called the PPOS, Paul Haydett and colleagues tool, the Patient Practitioner Orientation Scale. And our comparison group did, in fact, go down. And the CIC group, for the first time in the recorded literature, actually had a 3rd-year experience where they went up. And this has been true year after year after year. At the beginning, bless you, at the beginning there's no difference between the 2 groups, and at the end there is. So I think a lot of people and a lot of foundations and a lot of people outside of medicine are very excited by the idea that 3rd-year training could actually make people more, not less, patient-centered. We used a second tool to make sure we were not missing something, and the second tool said the same thing, totally different validated tool. And I show you it broken out. I could have shown you just the less than 0.005, but I broke it out, and in each different domain they were less affected by the hidden curriculum and more patient-centered. So probably there's something there. All right, so here's the summary. The students go into a wide array of specialty choices. All over the world and all over the country, these models are used to train specifically for community care, for social accountability, for community engagement, for health systems, for primary care, for family medicine, for rural health, for remote health even. We weren't allowed to do that. So we had to have our students be exactly the same as other Harvard students according to the school's demand of us. And it turned out that's what happened. When the students going in were randomly assigned, the students coming out chose the same fields as their classmates. They were equally likely to do research or do academic careers. The costs were equivalent to the cost reported in the literature. We expanded and the cost did not go up. Our reimbursement rate is the same as for every other hospital on a per student basis. For rural and remote places where you send students out 1,000 miles into Northern Ontario, into the Northern Territories of Australia, where they do this to great success, it costs a little more because they pay for the travel and the housing. But in closed system models like yours would be or like ours is, the cost is not different. The faculty believe it improves the quality of care to have a student in your office like this for the year. It's not a set of students in your office for the year. It's your personal student in your personal office for the year. And you can make that bright, excited, smart, energized person who wants to learn and do everything for you and your patients able to function on behalf of you and your patients in your office. A year is a big horizon. You can do very special things with having a student in your midst for a year. The same student for the same year. All right. It looks like the students' motivation to learn science and their rigor and their spirit of inquiry, their commitment, their duty, all of these core values stems from this idea that they feel as if it's their own patients. Something about that, it's my patients, it's my office, it's my doctor I want to appeal to, my attending, my overseer. Something about this commitment is connected to the ownership question. They also get into team care, not as some kind of carve out or some kind of soft thing. They recognize team care improves the quality and safety of their patients. So that's an experiential connection to team care. They really get into health systems issues. They really see problems with the system. They see the system through the eyes of their patient. It's very good for all the systems redesign work that's going on. These LIC models are growing up in places where systems redesign is very, very popular. And they believe that from educational change comes systems change. So it's very interesting. As our institution changed its capacity to educate students, And the structure of educating students, we actually had to change our institution, which was a good thing. We got a better institution out of the fact that we had to adhere to the educational needs of our students. You see here that Don Berwick, I'm citing Don Berwick here. I mean, clearly one of the great minds in American medicine, and it is he who thinks there's promise in this model for changing the system to better support doctors and patients. So I'll give you two more just to tickle you on the way out the door here. We can't change what? If it's not broken, why should we fix it? Why should we transform? I mean, can't we just sort of fine tune it? We can keep the blocks, but we can't get rid of the blocks. The truth is, it sounds cool. It kind of sounds like a good idea, but we're not ready here yet. We need more time. Well, what's the evidence that this new curriculum is better than the old curriculum? I'll comment on that in a second. And of course, what's wrong with the old curriculum? It produced me and I'm great. So, I mean, but in that, of course, is the truth that we do revere and regard and like and value what we did, and that's good. The question is not, though, whether we should hold ourselves to the standard of doing well enough. We should do better than well enough. We have to keep going. And that's what all of you who are in practice do all the time when you read or go to a conference or talk to a colleague about the case. Which leads me to the final sort of tickler. Until you have the data, they'll argue the data. But once you have the data, then, so change is hard, and all this data is not going to be the thing that compels change. The question for me is always whether the principles resonate enough for people to see all the possibility that comes out of longitudinal models, where you're connected to a student closely and you can do things differently for yourself and your office and your patients. So the principles more than the model, I think, are the thing to take out. Molly Cook, of course, is the Carnegie Foundation writer who redid the Flexner Report 2 years ago. So we can think of this last charge from the Institute of Medicine. A cultural shift towards an emphasis on the needs of patients and populations, communities, and a focus on improving health using the best of science and the best of caring. It's to our traditions. But that was in 2003. This is not, we're 9 years later, and I think there's a lot of happiness with imagining that we can actually do this through new models, whether they're LIC models or not, at least through new models, new re-envisioning. Frankly, it's not even new. It's about getting back towards the values and the way that it should have been and was. It's getting back to having students be at the center of the learning, patients be at the center of the learning, and students, patients, and faculty all together to do the good work. So we don't ever close a talk without thanking our students who were intrepid and willing to give it a try. So you see here the first 8 years of our students, and we're in the 9th year now with equally ambitious and delightful students who I imagine you will have also when you have people here. So anyway, there's just an idea of LICs. What it is not, though, is telling you should do LICs. I just wanted to make a compelling case for arguing how education reform can be kind of dynamic and interesting, and it's just one story.